Well, good morning. Welcome here to the Oversight Investigation Subcommittee hearing. I just want to say it's Mental Health Month, so it's fitting that we are here today on this issue. This is the third in a series of hearings examining the growing problem of prescription drugs and heroin addiction that is ravaging our country. This is our nation's single biggest public health concern. Over the past 5 weeks, the subcommittee has heard from addiction experts working with local communities and our leading academic and research centers. Dr. Robert DuPont, the former White House Chief of Drug Control Policy and the first director of the National Institute on Drug Abuse, testified that federal programs lack direction and standards on treating addiction as a chronic condition and noted what is being done to follow up with patients to prevent relapses and put them on a path of real recovery. He challenged us to even ask the most fundamental question, what is recovery? Dr. Anna Lemke of Stanford Medical School provided critical testimony on how we must revise our health care quality measures to reduce overprescribing, reform medical privacy regulations, and incentivize the use of prescription drug monitoring programs. We know that those with opiate addiction disorders need a broad range of treatment options, and that many with substance abuse disorders have co-occurring psychiatric disorder. But we need to tear down federal policy and funding barriers that keep us from treating both simultaneously. About 3 weeks ago, one of today's witnesses, Mr. Michael Botticelli, the director of the Office of National Drug Policy, presented a slide, I'm going to show it here, at the National RX Summit on major causes of death from injury from 1999 to 2013. Quite a revealing slide. While the trends of other major causes of death, such as auto accidents, went down, drug poisoning continued to go up 21% from 2008 to 2013. In many states, these numbers are soaring at high double-digit rate increases. As Mr. Botticelli has indicated to me privately and at the RX Summit, we must do better, and we have much work to do. Today, we will hear from federal agencies charged with providing guidance, direction, and leadership in our nation's public health response to the opiate epidemic. No federal agency has a more central role in this ongoing epidemic than the Department of Health and Human Services, or HHS. HHS and its Substance Abuse and Mental Health Services Administration, also known as SAMHSA, are responsible for leading our nation's public health response to the opioid, heroin abuse, and addiction crisis. SAMHSA regulates our country's 1,300 opiate treatment programs, and SAMHSA is responsible for certifying the 26,000 physicians who prescribe the most commonly used opioid maintenance medication, buprenorphine. According to testimony provided by SAMHSA before this subcommittee in April of last year, there were nearly 1.5 million people treated with these opioid maintenance medications in 2012, which is a five-fold increase in the last 10 years. Has SAMHSA defined the goal of recovery for what these federally subsidized treatment programs are supposed to accomplish? Is SAMHSA collecting and evaluating meaningful data at an individualized level that would hold grant recipients individually accountable for effective results? So far, a preliminary examination indicates the answers are no. And when you don't define where you're going, every road you take still leaves you lost. So we're hoping we can get some direction today. The numbers indicate we are failing as a nation, and we darn well better come to terms with that. The 43,000 lives lost last year, the thousands of babies born addicted to opiates tell us the terrible toll this epidemic has taken. You've heard my thoughts about the government-sponsored promotion of what I've characterized as addiction maintenance, and I've referred to buprenorphine as heroin helper, not because the medication is altogether lacking, because it is helpful, but rather because infrastructure the federal government has created for the use of this highly potent and important medication is not fully working, and worse yet, in many cases, it's contributing to the growing problem. This has to be fixed, and I hope we'll find some solutions, and that is what we need to discuss today openly, honestly, and humbly. If we do not reverse the current trend, where is this going to end? How many millions of citizens do we want to have on opiate maintenance? How many more must die? And how many more lives and dreams must be shattered before we recognize the depth of this national scourge? Now, I don't believe in better living through dependency, and again, please do not misconstrue this critique as a general indictment of opiate maintenance. It is not. For some people, opioid maintenance is the most appropriate bridge treatment, and there should be no shame or stigma associated with it. But opiate maintenance therapy should not be the only treatment offered to the opiate-dependent individuals, and it's not the only goal. What patients in opiate maintenance can be successfully transitioned off these medications? What protocols are best for effecting this transition? What are the best practices for prevention of relapse for those patients who end opioid maintenance treatment? There are non-addictive medications approved for this use, but are these medications widely available, and how well do they work? The diversion of buprenorphine for illicit non-medical use is a related problem because this is how the opioid epidemic can be spread. According to the DEA, buprenorphine is the third most often seized prescription opioid by law enforcement today. Where is the call to modernize our existing opioid addiction treatment system to ensure that the right patient gets the right treatment at the right time? Why aren't we hearing about expanding access to non-addictive narcotic treatments that have zero potential for abuse or diversion, such as naltrexone and evidence-based counseling? These are all incredibly important tools, and we want to make sure HHS talks more about these. Last week, Dr. Wesley Clark, the former director of SAMHSA's Center for Substance Abuse Treatment and the man who oversaw the growth of buprenorphine over the past decade, declared before the American Society of Addiction Medicine that many buprenorphine practices have become pill mills where doctors and dealers were increasingly indistinguishable and physician negligence and alleged laboratory fraud prevailed. The problem is not with buprenorphine, however. The problem lies with current practices, and this is what we need to discuss. I consider opioid maintenance as a bridge for those with addiction disorders to cross over in the recovery process, and as I've said, it's not a final destination. We seek to lay out a vision for recovery that includes complete withdrawal from opiates as an option. For cancer, for diabetes, for AIDS, we want people to be free of the diseases, not just learn to live with it. We need to commit the same sorts of things to our research and clinical efforts that boldly declare what we must change here. I thank our witnesses for being here today, and I now recognize the ranking member of the subcommittee, Mr. Gett from Colorado, for 5 minutes.
Thank you so much, Mr. Chairman. I think it's really important to hear from our witnesses today about the work the federal government's doing to address this serious public health issue. And I know all of the agencies represented before us do critical work to prevent and treat this epidemic. In March, Secretary Burwell announced an initiative to combat the opioid crisis. I applaud the department's actions, and I'm gratified to hear that this is one of the Secretary's top priorities. I want to hear more about this initiative today and how all the agencies before us are working together to accomplish its goals. But at the same time, I have some hard questions about our approach to caring for those who have substance abuse disorders. Last week, we heard from a panel of medical experts who have vast experience in treating opioid addiction. Unfortunately, as the chairman said, they gave us a fairly bleak view of the opioid treatment landscape in this country. For example, one witness, Dr. Adam Basaga, a psychiatrist at Columbia University and a research scientist at the New York State Psychiatric Institute, told the committee that the majority of patients being treated for opioid addiction receive treatment that is both, quote, outdated and, quote, mostly ineffective. He described this approach of rapid detoxification followed by an abstinence-only method without the use of important treatment medications. Dr. Basaga added that this is potentially dangerous because it raises the risk of an overdose if a patient relapses. As troubling as this testimony from our last hearing was, today we have Dr. Volkow on our panel, who is one of the world's top experts on addiction research. And she notes, I'm sure you'll talk more about this, Doctor, in her written testimony that, quote, existing evidence-based prevention and treatment strategies are highly underutilized across the United States. Why is that, Mr. Chairman? Why do we have experts week after week telling us that the bulk of the treatment Americans are receiving for this devastating disease are ineffective, outdated, and not evidence-based? We need to be asking ourselves some tough questions. For example, Dr. Westreich, the president of the American Academy of Addiction Psychiatry, told us last week, quote, patients and their families need to know that detoxification treatment and drug-free counseling are associated with a very high risk of relapse. Are patients enrolling in treatment getting sufficient data so they can make medically informed choices? Are families and loved ones being told what approaches have high failure rates before choosing an approach to treatment? Frankly, this is not a decision that should be taken lightly. Getting ineffective treatment may not only be financially costly, but it may result in a fatal relapse. Finally, Mr. Chairman, recent testimony, including some I saw in the written statements for today, raises important questions about whether taxpayer dollars should fund certain approaches for combating this opioid epidemic over others. This is an issue I've been talking about week after week. We all agree that we need the most effective treatment. And our experts agree that this treatment needs to be a broad menu of options that is different from patient to patient. So we might not have a silver bullet to cure opioid addiction at this point, but we do know what treatments work better than others. Evidence tells us, and all the medical experts we heard from last week agree, that for most patients, a combination of medication-assisted treatment and behavioral treatment, such as counseling and other supportive services, is the most effective way to treat opioid addiction. If that's the case, we should pursue more policies that encourage this approach as a clear option and steer away from any efforts that are not evidence-based. It's costly and it's dangerous to the patient. So I hope we can all work together to fight this epidemic, and I do look forward to hearing from all of our witnesses. I'm glad Secretary Burwell and the Department are devoting serious attention to addressing both the prevention and treatment sides of this problem. And Mr. Chairman, this has been a really great series. I'm happy to have a whole investigation like this in this committee. There's one group that we haven't heard from yet. I'm hoping we'll... Good. The states. We haven't heard from the states yet. It's critical we hear from them because that's where the rubber's hitting the road. We need to hear what the states are doing to address this problem and understand the reasoning behind some of the choices being made. Some states are picking effective treatment methods and others are not. So I think we need a multifaceted approach. This is what our research has showed, and I know we can work together to continue this important investigation. I just want to add one more note. The witnesses and the audience may see members jumping in and running out. We have another hearing in the Energy and Commerce Committee going on down on the first floor, so people will be coming and going. But I know certainly from my side of the aisle, people recognize this is a very serious issue. Thank you.
Thank you. And I know that they be calling votes at 9:30 or first vote series. If something's changed, first and only vote series of the day. I'm here for the duration, so we want to hear from you. And hopefully the members do. Now we recognize Mr. Upton.
We really are going to have votes at 9:30?
That's what it says now.
Well, I'm going to submit my statement for the record then.
Okay. All right.
You're back.
All right. Mr. Pallone, 5 minutes.
I'll do the same, Mr. Chairman, because we both have to go to the other hearing.
Okay. Okay. See how much we get along. Is there anybody else on either side that needs recognition? Go right into this. All right. Okay. Let me find my...
Oh, wait, Mr. Kennedy.
Mr. Kennedy? Where's my opening statement?
Oh, he wanted a minute. Oh, can I, here. Mr. Chairman, can I yield just 1 minute?
Yes, you can yield a minute to Mr. Kennedy of Massachusetts.
Thank you very much for the consideration. I yield back.
Okay. All right, let me now introduce the witnesses on the panel for today's hearing. We have the Honorable Michael Botticelli, the Director of the Office of National Drug Policy, which is part of the Executive Office of the President. Welcome here. Dr. Richard Frank, the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services. Dr. Nora Volkow is the Director of the National Institute of Drug Abuse with the National Institutes of Health. Dr. Douglas Throckmorton is the Deputy Director of the Center for Drug Evaluation and Research at the Food and Drug Administration. Dr. Deborah Houry, the Director of the National Center for Injury and Prevention and Control at the Centers for Disease Control and Prevention. The Honorable Pamela Hyde, the Administrator for Substance Abuse and Mental Health Service Administration. And Dr. Patrick Conway, the Deputy Administrator for Innovation and Quality and the CMS Chief Medical Officer at the Centers for Medicare and Medicaid Services. Welcome. So you are aware that, and I'll swear in the witnesses, that the committee is holding an investigative hearing, and when doing so has a practice of taking testimony under oath. Do you have any objection to testifying under oath? None of the witnesses have objection. The chair then advises you that under the rules of the House and the rules of the committee, you are entitled to be advised by counsel. Do any of you desire to be advised by counsel today? And none of the witnesses say so. So in that case, please rise, raise your right hand. I'll swear you in. You swear that the testimony you're about to give is the truth, the whole truth, and nothing but the truth. Thank you. All the witnesses answered in the affirmative, so you are now under oath and subject to the penalties set forth in Title 18, Section 1001 of the United States Code. You may now each give a 5 minutes opening statement. Please stick to the 5 minutes. If you don't have to fill it, that's okay too. We'd like to get through. Mr. Bonicelli.
Thank you, Chairman Murphy, Ranking Member DeGette, and members of the subcommittee for the opportunity to provide testimony to you today about the administration's efforts to address the opioid epidemic in the United States. Mr. Chairman, as you recognized, in 2013, almost 44,000 Americans died of a drug overdose. That's one drug overdose death every 12 minutes. Using ONDCP's role as the coordinator of the federal drug control agencies, in 2011 we published the administration's Prescription Drug Abuse Prevention Plan to address the sharp rise in prescription opioid drug misuse in this country since 1999. As you know, the plan consists of action items categorized under 4 pillars: education of patients and prescribers, increased prescription drug monitoring, proper medication disposal, and informed law enforcement. With the work of our HHS partners here today and other federal partners as part of the Interagency Prescription Drug Work Group convened by ONDCP, we have made some strides in each of these areas, but there is much more to be done. Since time in graduate medical education programs devoted to the identification of treatment of substance use disorders is rare, we have worked with our federal partners to develop continuing education programs about substance use, managing pain appropriately, and treating patients using opioids more safely. Many prescribers in federal agencies, including HHS, are receiving this important training. Despite this, a large percentage of prescribers have not availed themselves of this training. Therefore, the administration continues to press for mandatory prescriber education tied to controlled substance licensure. I am pleased that Secretary Burwell has expressed her support for working with Congress to set requirements for specific training for opioid prescribers. Today, all states but one, Missouri, have prescription drug monitoring programs that allow prescribers to check on drug interactions, as well as alert them to the signs of dependence on opioids. Missouri is also working to authorize a PDMP program. With almost all states implementing PDMPs, we are focusing on improving state-to-state data sharing and improving access to PDMP data within the health record system providers use every day. In October, the Drug Enforcement Administration's final regulation on controlled substances disposal became effective. ONDCP and our federal partners and stakeholders have begun to inform the public about these regulations and look to ways to stimulate more local disposal programs in partnerships with pharmacies, local government, community groups, and local law enforcement. And the work of our law enforcement partners at the federal, state, and local levels is ongoing. Those engaged in fraud across the drug control supply chain are being investigated and prosecuted. Recent data shows we are seeing an overdose from prescription opioids leveling off in this country, but a dramatic 39% increase in heroin overdoses from 2012 to 2013. This is creating an additional need for treatment in a system where a well-known gap between treatment capacity and demand already exists. Therefore, we must redouble our efforts to address people who are misusing prescription opioids, since we know this is a major risk factor for subsequent heroin use. Earlier this week, the administration held the inaugural meeting of the congressionally mandated Interagency Heroin Task Force. Mary Lou Leary, our Deputy Director for State, Local, and Tribal Affairs, is one of the co-chairs for this committee. In addition, the President's FY16 budget request includes $99 million in additional funding for treatment and overdose prevention efforts. We have also been working to increase access to the emergency opioid overdose reversal drug naloxone and to promote Good Samaritan laws so that witnesses can take steps to help save lives. Many police and fire departments have already trained and equipped their personnel with this life-saving drug, and loved ones of people with opioid drug use disorders are equipping themselves as well. And while law enforcement and other first responders have an important role to play, the medical establishment also must become more engaged to identify and treat heroin and prescription opioid use disorders. Every day, these people appear in our emergency departments and other medical settings, and more models and interventions are needed to get these individuals engaged in care. We also need to expand availability of evidence-based opioid use disorder treatments. Medication-assisted treatment, which uses FDA-approved medications combined with behavioral and other recovery supports, have been shown to be the most effective treatment for opioid use disorders. Decisions about the most appropriate treatment options and their duration need to be agreed upon by both the patient and the treatment provider. We must also provide community supports, such as access to housing, employment, and education, to give patients the functional tools they need to lead healthier lives and fully integrate into the community as part of their recovery process. While we support multiple pathways to recovery, the literature shows that short-term treatment, such as detoxification alone, is not effective and carries risk of relapse and overdose death. Because of the lack of availability of evidence-based maintenance treatments and the strong connection between injection of opioid drugs and infectious disease transmission, we also promote the use of public health strategies that will help prevent the further spread of infectious disease. The HIV and hepatitis C outbreak in Scott County, Indiana, is a stark reminder of how opioid use can spread other diseases, how comprehensive public health strategies, such as syringe exchange programs, need to be part of the response to the opioid use epidemic, and how rural communities that have limited treatment capacity may experience additional public health crises. Finally, we are continuing our efforts to address neonatal abstinence syndrome. Research published just yesterday shows that the incidence of NAS has grown nearly fivefold between 2000 and 2012, and that 81% of the 2012 hospital charges for NAS were attributed to Medicaid. We must consider that the best interest of babies with NAS is often served by best addressing the interests of the mother. Therefore, we need to provide safe harbor for pregnant and parenting women seeking prenatal care and treatment. In conclusion, we look forward to working with Congress and our federal partners on the next stage of action to address this epidemic. Thank you.
Thank you. Dr. Frank, we're going to try and get your testimony, then we're going to run off and vote, and we'll be back. Go ahead.
Okay. Chairman Murphy, Ranking Member DeGette, and members of the subcommittee, thank you for the opportunity to discuss how the Department of Health and Human Services is addressing the opioid abuse epidemic. Containing the abuse and misuse of prescription opioids and heroin is a high priority for the HHS leadership team, and we're pleased to be here with you today. I would like to use my time today to give you an overview of how we view the challenge and describe how we are working to develop a multifaceted solution to this problem. It's going to take a lot of collaboration, and we are pleased to work with you and other stakeholders on this issue. Addiction to and abuse of opioids, including both prescription painkillers and heroin, and the terrible outcomes associated with them, are growing at an alarming pace. Just over a third of drug overdose deaths in 2012 and 2013 were from prescription opioids, while heroin-related deaths have spiked dramatically, almost tripling since 2010. The sharp increase in the misuse and abuse of opioids places a great burden on the health system. There were 259 million prescriptions filled for opioids in the U.S. in 2012, a large increase over just a few years prior. The Medicare program under Part D spent $2.7 billion on opioids overall in 2011. $1.9 billion of that total, or 69%, was accounted for by the top 5% of opioid users. Those spending patterns on these drugs reflect some of our concerns. The cost of abuse and misuse of opioids shows up in preventable use of very expensive health care. Heroin presents an equally troubling but different abuse and overdose pattern. We saw increases between 2002 and 2009 in the number of people using heroin, but that number has held fairly steady since 2009. The striking new trend is that there's an increasing share of the users that are dying from heroin overdoses. So what I'm telling you is that we have an opioid prescribing problem sitting alongside a drug abuse and misuse problem. Secretary Burwell is committed to aggressively addressing the epidemic. She's driving us towards two main goals. One, reducing opioid overdoses and opioid and overdose-related mortality, and two, decreasing the prevalence of opioid use disorder. She directed us to use the best science and to focus on the most promising levers that can make a difference for the people who struggle with opioid addiction and their families. HHS agencies have been collaborating on this problem for some time, and we hope you will agree after today that the whole is greater than the sum of the parts. Our actions informed by the evidence and discussions with states and other stakeholders fall into three general categories. One, addressing opioid prescribing practices. Two, expanding the use of naloxone. And three, promoting medication-assisted treatment. Let me outline the plan in a bit more detail. First, PDMPs. We're increasing investments in prescription drug monitoring programs, which are among the most promising clinical tools to curb prescription opioid abuse. We're investing through state grants and technical assistance in supporting best practices to maximize the impacts of PDMPs. Second, naloxone, which is a life-saving drug that can reverse overdose from both prescription opioids and heroin. We're supporting the development of user-friendly formulations and delivery mechanisms and are working with state and local governments to support training and other measures that get naloxone into the hands of those that are in a position to reverse overdoses. Finally, we have plans to support the appropriate use of medication-assisted treatment, or MAT. The enactment of the Mental Health Parity and Addiction Equity Act opens up new opportunities to expand access to these evidence-based treatments. We're also working on identifying best practices in primary care settings, increasing access to MAT through SAMHSA grant support, and potentially increasing the supply of MAT providers by reviewing the policy and regulations that limit the types of individuals certified to prescribe. Our commitment to halting this complex public health epidemic is set out in the President's 2016 budget that includes a $99 million increase for parts of our initiative. Finally, evaluation will help us identify the most effective activities, allow us to continuously learn, and inform future policy making in order to address this public health concern. So in closing, this is critical for HHS and for the nation, and we can't do it alone. We need help. Thank you for encouraging an open discussion of this today, and we are committed to turning the tide on this scourge that has become the opioid epidemic.
Thank you, Doctor. Now for the members, so votes are in progress, and even though time is running out, just to let you know, I think only about 20 people voted so far, so apparently this is throwing everybody off in their schedules. I apologize if this is what happens on Capitol Hill, but we're committed to hear from you. We know how important this is and how we value your testimony. So we're probably going to be back in a little under an hour. So we look forward to hearing from you then and getting to the rest of this testimony. Thank you.
This is what you call testimonial interruption.
For being patient. Finish all the testimony. Thanks. All right, Dr. Volkow, you're recognized for 5 minutes.
Good morning, Chairman Murphy, Ranking Member DeGette, and other members of the subcommittee. I want to thank you for organizing and inviting me to participate in this important hearing. The non-medical use of prescription pain relievers is a particularly public health challenge, for it demands solutions on the one hand to prevent their diversions and misuse, while at the same time it demands some solutions that will not jeopardize access of these medications for those that need them. Opioid medications are probably among the most effective painkillers that we have for the management of acute severe pain, and the proper use can actually save lives. They act by activating opioid receptors that are located in the areas of the brain that perceive pain, but there are very high concentration of opioid receptors in brain reward regions, and hence the problem. And its activation of these receptors is what is associated with their addiction potential. There are also high levels of receptors in areas of the brain that regulate breathing, which is why their use is associated also with a high risk of death from overdoses. We have heard the devastating consequences from the escalation of the abuse of prescription medications in our country, the overdose deaths, the transition to injection of heroin, and associated infections with HIV and hepatitis C, and the increasing numbers that we're seeing on the neonatal abstinence syndrome. NIDA's role in helping solve this epidemic is to support the research that will help develop solutions to prevent and treat abuse of prescription medications that could be implemented now, while at the same time funding research that in the future will provide transformative solutions. There are already evidence-based practices that have been shown to be effective in the prevention of overdose death. That include the use of medications for opioid addiction and the use of naloxone to reverse opioid overdoses. There are 3 medications currently available to treat opioid addiction: methadone, buprenorphine, and naltrexone, which, when used as part of a comprehensive addiction treatment plan, have been shown to facilitate abstinence and reduce overdose and HIV infections. Also, when coupled to prenatal care in pregnant women addicted to opioids, these medications reduce the risk of obstetrical, fetal, and neonatal complications. Yet, despite the strong evidence, less than 40% of those receiving treatment for opioid addiction get treated with these medications. Towards this end, NIDA is funding research on implementation strategies that facilitate the use of medications for opioid addiction in the healthcare system. Another key component to decrease the overdose deaths is to expand the use of naloxone. So NIDA has partnered with pharmaceutical companies to develop user-friendly, effective delivery systems for naloxone that will facilitate their use by those that have absolutely no medical training. In addition, NIDA supports research on the treatment of pain and on the treatment of opioid addiction that will offer new solutions for the treatment of these 2 disorders. Examples, for example, for the management of pain include the development of drug combinations or new formulations with less addiction potential, the development of analgesics that do not rely on the opioid system, and the development of non-medication interventions such as the use of transcranial magnetic or electrical brain stimulation for pain management. Examples of research on the treatment of opioid addiction include the development of slow-release formulations that need only once a month or once every 6 months dosing, which will facilitate compliance and use, and the development of vaccines against heroin, which will prevent the delivery of the drug into the brain, hence interfering with its rewarding effects and adverse consequences. Because the epidemic of prescription drug abuse resulted from a lack of knowledge by healthcare providers, the importance of developing curriculum to train both in pain and in substance use disorder is another priority for which NIDA has developed in partnership with the other institutes and NIH centers of excellence. There are over 24,000 deaths from opioid overdoses in 2013, 24,000. This highlights the urgency to address this epidemic. Solutions are already available. The challenge is the implementation. This requires strong integration of efforts, and NIDA will continue to work closely with other federal agencies, community organizations, and private industries to address this complex challenge.
Thank you. Dr. Throckmorton, 5 minutes.
Mr. Chairman, Ranking Member DeGette, and members of the subcommittee, I am Dr. Douglas Throckmorton, Deputy Director for Regulatory Programs within FDA's CEDAR Center for Drug Evaluation and Research. Thank you for the opportunity to be here today to discuss FDA's role in combating opioid abuse and encouraging the safe use of these important drugs. Our goal is to find the balance between needing to treat patients with pain, including the use of opioids where appropriate, and needing to reduce opioid drug abuse. This work is being done together with other parts of the federal government, and we know that a successful and sustainable response must include federal and state government, public health officials, opioid prescribers, addiction experts, researchers, manufacturers, and patient organizations. For our part, FDA plays a central role in the regulation and use of drugs from their discovery and throughout their marketing. For example, when FDA reviews a drug for possible marketing, we also approve drug labeling, which includes information for approved uses about the medicine, as well as information about potential safety risks. FDA also follows drugs after they are marketed carefully, including opioid drugs. Where necessary, this enables us to take a variety of actions to improve their safe use, such as changes to approved labeling. The first area of FDA activity I'd like to highlight is our work to support the development of abuse-deterrent formulations that make opioids harder or less rewarding to abuse. While this is not a silver bullet that will prevent all abuse, FDA believes abuse-deterrent opioids can help reduce opioid abuse. To incentivize their development, FDA recently issued final guidance on abuse-deterrent formulations, guidance we are using now to meet with sponsors interested in developing them. To date, FDA has received some 30 investigational new drug applications from manufacturers. In addition, we have approved 4 opioid drugs with abuse deterrent claims in their labeling. Overall, then, while we are in the early stages of their development, I am encouraged by this level of work. FDA envisions a day not far in the future when the majority of opioids in the marketplace are in effective abuse deterrent forms. Next, with regards to prescribing opioids, we know that they are powerful medicines, and FDA believes that it is critically important to ensure that prescribers have high-quality education about how to use them in pain management. Over the past several years, FDA has done several things to improve educational materials on opioids. For example, we recently finalized required changes to the approved labels of extended-release long-acting opioids, changing their indication to inform prescribers that these drugs should only be used for pain severe enough to require daily, around-the-clock treatment when alternative treatments would not work. At the same time, FDA strengthened significantly the safety warnings on these opioids. We want prescribers to use them with care. And today, the labels for extended-release long-acting opioids are among the most restrictive of any drugs that we have in the center, and have clear language that calls attention to their potentially life-threatening risks. FDA is also working to improve the information available for prescribers in other ways. Under certain circumstances, FDA can require manufacturers, as a part of a risk evaluation and mitigation strategy, to address safety concerns such as opioid abuse. In 2012, FDA required manufacturers to fund the development of unbiased continuing education programs on opioid prescribing practices for prescribers. In the first year since that program has been in place, approximately 6% of the 320,000 prescribers, around 20,000 prescribers of extended-release and long-acting opioids, have completed one of those courses. We believe this training for prescribers is important. We also support mandatory education for prescribers of opioids, as called for by the administration in the 2011 Prescription Drug Abuse Prevention Plan and reemphasized in the 2014 National Drug Control Strategy. Finally, FDA has been working with many other stakeholders, including the agencies here today, to explore the best ways to prevent overdose deaths by the expanded use of naloxone. As others have said, it can and does save lives. FDA is working to facilitate the development of naloxone formulations that could be easier used by anyone responding to an overdose. First, FDA meets with manufacturers whenever needed and is using whatever tools we can to expedite product development. We recently approved the first auto-injector formulation of naloxone, which is intended to be administered by people witnessing an overdose, such as family members and caregivers. We completed that review and approved this product in 15 weeks. Going forward, we continue to work on how best to use naloxone. As a part of this work, FDA and many of the other agencies at this table are planning a public meeting in July to bring together key stakeholders to deal with questions of access, co-prescribing of naloxone, and state and local best practices. In conclusion, as a society, we face an ongoing challenge and a dual responsibility. We must balance efforts to address opioid drug misuse, abuse, and addiction against the need for access to appropriate pain management. These are not simple issues, and there are no easy answers. FDA is taking important actions we hope will achieve this balance. We welcome the opportunity to work with Congress, our federal partners, the medical community, advocacy organizations, and the multitude of interested communities and families to turn the tide on this devastating epidemic. Thank you for this opportunity to testify. I look forward to answering any questions that I can.
Thank you, Doctor. Dr. Howard.
Chairman Murphy, Ranking Member DeGette, I would like to thank you for inviting me here today to discuss this very important issue. I'd also like to thank the committee for your continued interest in the prescription of opioid abuse and overdose. My name is Dr. Deborah Howery, and I am the Director of the National Center for Injury Prevention and Control at the CDC. As a trained emergency room physician, I have seen firsthand the devastating impact of opioid addiction on individuals and their families, as well as the importance of prevention. Together, we have witnessed a deadly epidemic unfolding in states and communities across the country. The overdose epidemic is driven in large part by fundamental changes in the way healthcare providers prescribe opioid pain relievers. Enough prescriptions were filled in 2012 for every American adult to have their own bottle of pills. As the amount of opioids prescribed increased, so has the number of deaths. In alignment with the department's initiative, I want to highlight CDC's work in developing evidence-informed opioid prescribing guidelines for chronic pain, and providing direct support to states to implement multi-sector prevention programs. CDC is currently developing guidelines for the prescribing of opioids for chronic non-cancer pain. This undertaking is responsive to a critical need in the field. These new guidelines will redefine best practices around opioid prescribing for chronic pain and make important advances in protecting patients. The audience for these guidelines are primary care practitioners who account for the greatest number of prescriptions for opioids compared to other specialties. The guidelines process is underway, and our goal is to share a draft for public comment by the end of this year. We have plans in place to encourage uptake and usage of the guidelines among providers, which is key for improving prescribing practices. The second activity I'd like to highlight is our major investment in state-level prevention. States are at the front lines of this public health issue, and CDC is committed to equipping them with the expertise they need to reverse the epidemic and protect their communities. Utilizing the newly appropriated $20 million, we recently published a new funding opportunity called Prescription Drug Overdose Prevention for States. It builds upon existing CDC-funded state programs and targets states that have a high drug overdose burden and those that demonstrate readiness needed to combat the epidemic. It requires collaboration across sectors for a truly comprehensive response. The goals for this program are to make prescription drug monitoring programs more timely, easier to use, and able to communicate with other state PDMPs, to implement Medicaid or workers' compensation interventions to protect patients at risk, and to bring data-driven prevention to the communities struggling with the highest rates of drug abuse and overdose. States also will be given the flexibility to use the program to respond to emerging crises and develop innovative interventions so they know what works to reduce overdose and save lives in their community. The development of opioid prescribing guidelines and our state prevention program are two key ways that CDC's broad work on the epidemic contributes to the department's initiative. We are also examining the increase in heroin use and overdose. Heroin overdose deaths have more than doubled since 2010, and prescription opioid abuse, a key risk factor for heroin use, has contributed significantly to this rise in heroin use and overdose. We will leverage our scientific expertise to improve public health surveillance of heroin and evaluate effective strategies to prevent future heroin overdoses. Addressing this complex problem requires a multifaceted approach and collaboration among a variety of stakeholders. But it can be accomplished, particularly with the ongoing efforts of all of the organizations represented here on this panel. CDC is committed to tracking and understanding the epidemic, supporting states working on the front lines of this crisis, and providing healthcare providers with the data, tools, and guidance they need to ensure safe patient care. Thank you again for the opportunity to be here with you today and for your continued work and support of us protecting the public's health. I look forward to your questions.
Thank you, Doctor. Madam Hyde, welcome back.
Good morning, Chairman Murphy, Ranking Member DeGette, and members of the subcommittee. Thank you for inviting SAMHSA to be part of this hearing, and thank you for your interest in this important public health issue. According to SAMHSA's National Survey on Drug Use and Health, the prevalence rate of non-medical use of prescription opioids is high, approximately 4.5 million individuals in 2013. Heroin use is much lower, about 289,000 individuals reporting past month use, but that's doubled in 5 years. Fortunately, the non-medical use of pain relievers has actually decreased some from 2009 to 2013, especially among young people, 12 to 17. However, as you know, overdoses and overdose-related deaths from both prescription drugs and heroin have risen dramatically among all ages. And as you've heard, few who need treatment are receiving the comprehensive community-based services they need to live lives in recovery, free of addiction. SAMHSA believes prevention is the priority and recovery is the goal. SAMHSA's programs, data, practice improvement, public education, and regulatory efforts are all designed to prevent addiction and overdoses, help provide the treatment and services needed for people with substance use disorders to achieve recovery, support their families, and foster supportive communities. SAMHSA funds the American Academy of Addiction Psychiatry together with 6 other medical societies to train prescribers in the best approaches to pain management. SAMHSA also educates physicians on medication-assisted treatment for opioid addiction. SAMHSA's addiction technology transfer centers provide training and materials on opioid use disorders and are co-funded with NIDA to distribute research-based best practices to the field of addiction treatment. To help prevent opioid overdose-related deaths, SAMHSA alerted states last year that substance abuse treatment block grant funds may be used to purchase and distribute naloxone and increase education and training on its use. Also in 2014, SAMHSA updated its opioid overdose prevention toolkit to educate individuals, families, first responders, and others about steps to prevent and reverse the effects of opioid overdoses, including the use of naloxone. This toolkit's one of the most downloaded resources on SAMHSA's website. The President's 2016 budget includes $12 million in discretionary grants for states to purchase and distribute naloxone, equip first responders in high-risk communities, and support education on the use of naloxone and other overdose prevention strategies. SAMHSA also supports medication-assisted treatment as part of a recovery-oriented, person-centered care model. Medication-assisted treatment is not meant as a standalone approach, but rather is designed to include medication, counseling, behavioral therapies, and recovery supports. In March 2015, SAMHSA issued revised federal guidelines for opioid treatment programs which highlight this recovery-oriented care model and encourage the use of any of the 3 FDA-approved medications for the treatment of opioid use disorder based on an assessment of each individual's unique needs. SAMHSA is also taking an integrated clinical care approach as part of a new 2015 grant program to expand and enhance the availability of medication-assisted treatment and other clinically appropriate services in states with the highest rates of opioid admissions. The President's 2016 budget proposes to double this program. In collaboration with DOJ and ONDCP, SAMHSA added language to its 2015 treatment drug court grant requirements to ensure that drug court clients will not be compelled to stop or be prevented from using medication if it is prescribed or dispensed consistent with the licensed prescriber's recommendation, a valid prescription, or as part of a regulated opioid treatment program. SAMHSA regulates opioid treatment programs, which are expected to provide a full range of services for their patients. In collaboration with the Drug Enforcement Administration, SAMHSA provides waivers to physicians wishing to treat opioid use disorders with buprenorphine in a practice setting other than an opioid treatment program. SAMHSA also funds efforts to help prevent prescription opioid misuse and heroin use. For example, in 2014, SAMHSA's Strategic Prevention Framework, Partnerships for Success program, made preventing and reducing heroin use one of its focus areas, along with prescription drug misuse and abuse and underage drinking. For 2016, the President has proposed $10 million for the Strategic Prevention Framework RX, or SPIF-RX, to help states use data, including PDMP data, to identify and assist communities at high risk for the non-medical use of prescription drugs. We want to thank you again for taking on this issue and for allowing SAMHSA an opportunity to share some of its efforts with you. We look forward to answering your questions.
Thank you, Ms. Sy. Dr. Conway, you're recognized for 5 minutes.
Chairman Murphy, Ranking Member DeJette, and members of the subcommittee, thank you for inviting me to discuss the CMS's work to ensure that all Medicare and Medicaid beneficiaries are receiving the medicines they need while also reducing and preventing prescription drug abuse. As we've heard from other witnesses, opioid analgesics have increasingly been implicated in drug overdose deaths over the last decade. As a practicing physician, I understand the importance of this issue. CMS recognizes our responsibility to protect the health of Medicare and Medicaid beneficiaries by ensuring that appropriate safeguards are in place to help prevent overuse and abuse of opioids, while ensuring that beneficiaries can access needed medications and appropriate treatments for substance abuse disorder. Since its inception in 2006, the Medicare Part D prescription drug benefit has made medicines more available and affordable, leading to improvements in access to prescription drugs and better health outcomes. Despite these successes, Part D is not immune from the nationwide epidemic of opioid abuse. CMS has broadened its initial focus of strengthening beneficiary access to prescribed drugs to also address potential fraud and drug abuse by making sure Part D sponsors implement effective safeguards and provide coverage for drug therapies that meet safety and efficacy standards. We believe that broader reforms that result in better coordinated care will help protect beneficiaries from the damaging effects associated with prescription drug abuse and to prevent and detect overutilization related to prescription drugs. A centerpiece of our strategy is to strengthen CMS's monitoring of Part D plan sponsors' drug utilization management programs to prevent overutilization of these medications. To accomplish this goal, the Medicare Part D Overutilization Monitoring System, or OMS, was implemented in 2013.
Through this system, CMS provides reports to sponsors on beneficiaries with potential opioid overutilization, identified through analysis of prescription drug event data and through beneficiaries referred by the CMS Center for Program Integrity. Sponsors are expected to utilize various drug utilization monitoring tools to prevent continued overutilization of opioids. Recent data has shown that from 2011 to 2014, the OMS has reduced the number of potential opioid overutilizers by approximately 26%. CMS also utilizes the drug integrity contractor MEDIC, which is charged with identifying and investigating potential fraud and abuse and developing cases for referral to law enforcement agencies. In 2013, CMS directed the MEDIC to increase its focus on proactive data analysis in Part D. CMS has also used our rulemaking authority to create new tools to take action against problematic prescribers and pharmacies. We recently finalized a provision that requires prescribers of Part D drugs to enroll or have a valid opt-out affidavit on file and establishes a new revocation authority for abusing prescribing patterns. State Medicaid agencies have also taken action to tackle the opioid abuse epidemic. Efforts include expanding the Medicaid benefit to include behavioral health services for those with addiction to prescription drugs and pharmacy management review programs. Although CMS does not determine what services are provided in each Medicaid program to prevent and treat opioid abuse, we are encouraged by the increasing efforts by states to develop effective strategies for designing benefits for this population. We recently launched the Medicaid Innovation Accelerator Program, or IAP, to provide states with technical assistance and other types of support to address this important issue. CMS, in coordination with CDC, SAMHSA, and NIH, issued an informational bulletin on medication-assisted treatment for substance abuse disorder in the Medicaid program. This guidance outlined that a combination of medication and behavioral therapies is the most effective combination of treatment. We issued a similar bulletin focused on these services and the pediatric and youth population. CMS is dedicated to providing the best possible care to beneficiaries with opioid addiction, is working with Part D sponsors and state Medicaid programs to implement effective safeguards to prevent opioid abuse and treat patients effectively with substance abuse disorders. CMS has made progress, but there's more work to be done. CMS is undertaking multiple policy initiatives and interventions to reduce the rate of opioid addiction and overdoses in both Medicare and Medicaid. In previous testimonies, I've never had family here or the time to thank them, so I do want to thank my mother, Diane Conway, who's here, and my son, Jack, who's out of school, as well as my wonderful wife, Heather, and daughters, Alexa and Savannah. And without their love and support, I would not be able to work on issues like this that are critically important to our nation. So thank you.
Thank you, Doctor, and thank you for recognizing Take Your Family to Testifying Day. Apparently everybody else did not get the memo, so... I just want to start off by saying if talent and dedication alone could solve this crisis, we'd be there with the testimony of today and other days, but obviously we still have problems. So let me start off with asking a few questions. First, for Director Botticelli, for the Office of National Drug Control Policy, or ONDCP, uses the term recovery. Does it mean to include patients with opioid addiction in a buprenorphine or methadone treatment program and still using heroin or other illicit drugs, or would you say that's not recovery?
So I think, from our perspective and also as a person in recovery, clearly we want to make sure that people are continuing to progress in their recovery, and that kind of free from substances is the ultimate goal of recovery programs, and I think everyone would agree on that. But we also know that substance use, and particularly opioid use disorders, are a significant chronic disorder, and that oftentimes, and even my own experience show me, that people often will experience relapse and will often, I think, need multiple attempts at treatment to get to that final goal of long-term recovery and long-term abstinence. And so we really want to make sure that we're continuing to engage with patients, that we're moving them toward better health, better recovery, and being free from substance use as part of long-term recovery.
Well, let me ask in the context of this, because we also heard from testifiers last week, they felt there was not a uniform definition of recovery. But, I mean, this is the talent pool here. You're the ones that do these. Do you all meet on a regular basis to talk about these issues? And when was the last time you all got together to talk about policy issues? Was it within the last... Can someone answer that, Pam?
So let me start.
Oh, you'll start? Okay.
Let me start by that, because it's actually part of our statutory authority that we set in conjunction with not just our HHS partners, but with all of the federal agencies that have a role in substance use, and particularly in opioid use disorders. We've been engaged with the DOD and the VA and the Bureau of Prisons.
So you all meet regularly?
We actually do meet regularly, so we have quarterly meetings to focus on where we are.
Well, let me move on with that too, because that's going to be important. Ms. Hyde, let me ask you a question here on in your response to our bipartisan letter of March 18th concerning the National Registry of Evidence-Based Programs. You noted that, quote, new submission and review procedures will improve the rigor of the registry and bring NREPP into closer alignment with other registries of evidence-based program in the federal government, unquote. Now, prior to entering into this July 2014 contract, did SAMHSA feel that the scientific basis of rigor of NREP needed to be strengthened, yes or no? I mean, do you feel it needed to be strengthened?
Thank you for the question. We thought the process that we used for determining what practices were reviewed needed to be strengthened, and in the process we have also increased the rigor with which we look at them. Can
you get us a list, not today, but you can get us a list of what you consider to be some of the models within the federal registry that we can review as part of that as evidence-based programs?
Certainly.
Okay, thank you. Your response also indicates an outside contractor will assume the role of gatekeeper for NREP, determining which studies and outcomes are reviewed in the screening and review of an intervention with the aim of preventing bias in favor of the intervention developers. Was SAMHSA's prior system for vetting and selecting interventions to be included in NREP prone to any kind of developer bias or conflict of interest? Was that a concern?
Yes, Mr. Murphy, it was a concern. It was pretty much developer-driven, so a developer had to want their practice to be reviewed, and then they had some control over what research we looked at. We've changed that with the new contract, which began last year, and we will help decide priorities together with the public input, but the contractor will help us look more objectively at evidence.
Thank you. I just pulled up here, I just got a note, it was actually an article that, was this one of your constituents, Dr. Frank, from Eastern Colorado? I don't want to take all your Colorado thunder, but it was a fascinating article because it made reference to the increased use of emergency departments associated with opiates. And it's interesting, they said that the reasons for this is, first of all, they said there's 10.5 million estimated people with this is probably an underestimate. That people go to the emergency rooms for treatment for withdrawal, but also many trying to get more opiates. And that when you have users with opiate prescriptions from more than one physician, they're more likely to be involved in riskier practices. I wonder if any of you could comment on if that's an area that we're trying to address. I think, Dr. Volka, you were also talking about issues with regard to prescribing practices, and Dr. Frank, can some of you comment on those issues?
Yes, and I think that article, I think that you're referring to the New England Journal of Medicine article that shows that there's been a very significant quadruple number of cases of neonatal abstinence syndrome in the intensive care units. And this does reflect the fact that many women are actually being prescribed opioid medications during the pregnancy itself. Mm-hmm. And actually, based on another study, it was estimated that 21% of women that are pregnant are going to receive an opioid medication, which again highlights the need to enforce better that the guidelines on the management of pain need to be enforced in better ways. And this is also recognized by studies that have actually evaluated the extent to which physicians are following guidelines by the main medical organizations as it relates to the management of pain. So that is an area where there needs to be an aggressive increase in the education and enforcement of guidelines.
Thank you. I'm out of time. I just asked unanimous consent that I could submit this research article for the record. Ms. DeGette, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Dr. Volkow, as I mentioned in my opening statement, you're one of the world's top experts on the issue of treating addiction. Briefly, what does the body of scientific evidence show regarding the effectiveness of methadone and bupropion in this treatment of opioid abuse disorders?
What the research has shown, and it has shown it not just for methadone and buprenorphine, but with a more recent medication, naltrexone, that these medications, when used as part of a comprehensive program for the treatment of opioid addiction, are quite effective, and they significantly improve the outcomes of individuals being able to stay, on the one hand, abstinent from the drug or to decrease the likelihood of relapsing, but it also protects them against the adverse outcomes such as overdoses.
So, in light of those studies, you also said in your testimony that existing evidence-based prevention and treatment strategies are highly underutilized across the United States. And last week we had an expert tell our panel that very few patients with opioid addiction today receive treatments that have been proven most effective. He was talking about this rapid detox followed by abstinence-based treatment. I'm wondering, Dr. Volkow, if you can help understand this. Why do we have a situation where people are not getting evidence-based treatment?
Well, one of the problems has been, and it's a complex problem, and there are many reasons why they are not getting the correct treatment, including the fact of adequate education as it relates to the proper screening and management of substance use disorder, including the healthcare system. Then you have a whole infrastructure that has developed because addiction is stigmatized. So therefore, the likelihood of people accessing that medical care is much lower. So, and then of course, there is a difference between states on the way that they implement the treatment. So all of these factors account for the current situation.
Dr. Frank, do you have anything to add to that?
Yes, I do. I think that one thing that's very important to remember is that overall, we treat 10% of the people with these disorders. So it's not surprising that people aren't getting evidence-based treatment because they're not getting treatment, period. Second part is, why aren't they getting evidence-based treatment among those who do? And I think that there are insurance dynamics that hopefully we're fixing. There are, as Dr. Volkow said, access to trained professionals who are trained in the best things. And then there's, in a sense, trying to kind of get the systems and the infrastructures aligned so that they support the best practices.
Dr. Oury, several of our witnesses, including you, mentioned the role of the states in this. Can you talk about that for a minute?
Absolutely. I think states have different populations, different issues, different prescription drug monitoring programs. And so tailoring these programs for states so they can best identify whether it's their state Medicaid program, other high-risk programs or patients, and how to best target them. And that's why the program at the CDC is really helpful, because we have the higher level view to work across the states for this.
And do you think the states have work to do in terms of implementing these programs that are science-based and that work?
You know, I think we're starting to do that. Like, our program itself has only been in existence for 6 months, but we're seeing great progress. And if you look at some of the policies that states are implementing, we're seeing reductions in what we call doctor shopping and patients going, to different doctors because of utilizing prescription drug monitoring programs. So although it's early in the stage, I'm very optimistic that we are making progress in the states.
Okay. Dr. Volkow, I want to come back to you. One of our other experts last week said patients and their families need to know that detoxification treatment and drug-free counseling are associated with a very high risk of relapse. I'm wondering if you can tell us what the science shows. Is this type of treatment generally effective or less effective? What does the research show?
The research has shown that in general, fast detoxification of patients is associated with increased mortality, like what you just mentioned. And this reflects the fact that addiction is a chronic disease, and the changes that occur in the brain persist months, years after you stop taking the drug. So what they do in this fast detoxification is just remove the physical dependence and assume that the addiction is cured. And these are two independent processes. And as a result of that, the patient feels that they are safe, and then they relapse because they are still addicted.
Thank you.
And many times they overdose.
Thank you. Thank you very much, Mr. Chairman.
Okay. Now recognize Mr. Collins for 5 minutes.
Thank you, Mr. Chairman. This is truly a fascinating topic we're discussing, and it's obvious there's no very easy solution. I mean, we've heard it's a chronic disease, 10% are seeking treatment. I guess my question maybe for Ms. Hyde at SAMHSA is, certainly with pregnant women, that may have young kids at home, and inpatient treatment might be the preferred, and we just can't let perfect be the enemy of good. What other options are you looking at for people who can't get in? I mean, they're just not going to enter inpatient, so they may be part of the 90% not getting treatment at all. Some treatment better than no treatment, as frustrating as that might be. What are your comments to the young mother that's got kids at home and she's pregnant and she's dependent and she just can't go into an inpatient center? What do we do for that patient?
Thank you for the question. The issue of pregnant and parenting women is a big one in our field. We do have a small program to address that issue, but you're right, it's a residentially based program. We have increasingly been looking at ways to take what we learn in that program about the best ways to treat pregnant and parenting women and take it into other settings. So whether it's our opioid treatment programs or the training that we do for physicians who are using medication-assisted treatment to deal with pregnant and parenting women. So we're trying in every way that we can to make those services available to those women.
So again, with pregnant women, and we're looking at other treatments, I guess, whether that's buprenorphine or methadone, are there studies that show whether that has an impact on the fetus and the baby?
You're right to be concerned about the child. What we see is that this prevents death. It prevents addiction of the baby. It prevents a lot of other issues that may come with allowing or the young woman to continue with the illicit drug use or the prescription opioid misuse. So definitely providing treatment helps both the woman and the child.
Now, as you've counseled these women, what kind of reaction are you getting? Are they recognizing, and you would think, the genuine concern they have for the baby? I mean, they're very much a complicated balancing act going on here. What kind of reactions are you getting from the women acknowledging the problem and wanting to treat it?
You know, most pregnant and parenting women really want to do the best thing for their babies, and they want to do the best thing for themselves. But as you've heard, addiction is a chronic disease, and it's very difficult. It changes the brain, changes the ability to make decisions. The women who are in the programs that we provide support for find it a very helpful program with the kind of supports, because we provide a range of programs, and we've recently introduced medication-assisted treatment into those programs as well.
So are these women finding you on their own, or are their physicians guiding them to you?
The women who come to our programs come from a variety of places, some from the correctional system, some from physicians, some from family, some from self-referral. So they come from a number of places, and we don't make a distinction between where they come from in terms of providing the care.
Well, it's something this committee is very concerned with. And again, Mr. Chairman, thank you for holding this hearing and for all of your testimony. I wish there was an easy solution. There just doesn't appear to be one. So this is going to have to be addressed on a lot of fronts. And with that, I yield back.
Ms. Taco, you're recognized now for 5 minutes.
Thank you, Mr. Chair. And let me join in welcoming the Conway family to the hearing. And let me compliment the Honorable Michael Botticelli for having the roots, origins in the 20th Congressional District of New York. So welcome all. One of the biggest concerns I hear from individuals and families struggling with addiction is the difficulty they have accessing treatment. As you know, with the Mental Health Parity and Addiction Equity Act, as well as with our Affordable Care Act, millions more people have gained access to mental health and substance use services. However, recent reports have laid bare the fact that these new treatments as options sometimes exist on paper only. So my question first to Assistant Director Frank. Dr. Frank, what is HHS planning to do to increase the public disclosure of the Medicaid management practices insurers use both on the commercial side and on Medicaid and CHIP so that consumers can truly evaluate their health plans to ensure they are in compliance with parity?
Thank you for the question. We, too, view the Mental Health Parity Act as an incredibly important opportunity to increase the use of evidence-based practice and access to treatment. We're doing a number of things. We work with both the Department of Labor on the ERISA side of the commercial health insurance side. We've trained the ERISA investigators in how to detect deviations from parity arrangements within insurance. And so they are out there fully trained now working on these issues. We have a group within HHS who regularly provides technical assistance to state insurance commissioners and works with them to resolve complaints as they arise. And we've done a continuous series of forums and technical assistance around the country. And we're working with stakeholders, some of whom are in this room today, to improve our ability to ask for disclosure and to offer up consumers the opportunity to really make that evaluation that you referred to.
Thank you, Assistant Secretary. And Director Botticelli, would like to talk about another barrier to treatment for some patients. And press accounts have suggested that some states are denying patients access to drug courts if they are receiving medication-assisted treatments or MATs. I understand this has been a problem in Kentucky, at least according to some press accounts. So, Director, can you explain what is going on here? Given the importance of MATs, why are some judges attempting to cut patients off of medicines that can actually help them recover?
Thank you, Congressman. And as many of my colleagues have talked about today, increasing access to medication-assisted treatment along with other behavioral therapies is the best course of treatment for people with opiate use disorders. Unfortunately, one of the access issues that we find, in addition to issues around payment, have been particularly lack of access within the criminal justice system. And we know that many people with opioid use disorders are ending up in our system. Drug courts, some drug courts have not adapted policies that the National Association of Drug Court Professionals endorse in terms of ensuring that people who are on who do have an opioid use disorder get access to those medications, as well as not predicating their participation that they get off these medications. Part of what we've been doing on the federal level is using our federal contracting standards to ensure that people with opioid use disorders, whether it's in a drug court or a treatment program or in other venues, are offered access to medication-assisted treatment and are not denied participation based on the fact that they are on physician-prescribed medication.
Mm-hmm. Dr. Valco, on that same issue, do you agree with the assessment?
Yeah, I agree very much, and at the same time, we are developing alternatives that may be more amenable for the criminal justice system, like prison or jail, like the naltrexone antagonist. So there is no reason why they should not get access to medication.
Okay, and another barrier that patients face is the lack of available treatment providers who can prescribe MATs. Director Botticelli, can you comment on this dearth of providers who can prescribe buprenorphine, for example? What are some of the reasons for this shortage, and what can we do to address it?
One of the other opportunities that we have is ensuring that all of our treatment programs either offer medication-assisted treatment or to refer to programs that have medication-assisted treatment. An analysis of our treatment programs show that a very low percentage of them have incorporated medication-assisted therapies into their programs. Some of this, Congressman, quite honestly, has been by myth and misunderstanding and this divide between abstinence-based care and medication-assisted treatment, which I think is really unfortunate that we have here. So we really want to make sure that if a client is entering a treatment program that has particularly federal funding, needs to offer by way of its own offering or through referral medication-assisted treatment.
Right. Thank you very much, and thank you to the entire panel for guiding us in this crisis situation.
I just want to ask as a clarification for the question you were asking about the drug courts and the use of a medication-assisted treatment. So you're recommending medication-assisted treatment as part of an option package, although you say obviously we want to get people free from drugs altogether. Does it require a recommended practice from your agencies to get drug courts to do that? Does it require regulatory changes from one of your agencies to do that, or does it require a legislative solution from us to do that?
And other panels could add. We've actually been doing that as a condition of their federal drug court language.
Okay.
Again, we want this to be decided by an expert in addiction services in consultation with the parents.
Okay.
But we just didn't want to have categorical denial.
Ms. Hyde, are you adding to that?
I did mention in consultation with ONDCP and also with the Department of Justice, we have changed the language in our request for applications for drug courts so that they can't require that someone either get off of or not be on medication-assisted treatment if it is prescribed appropriately by a physician or a certified program.
So I just wanted to add, though, what you can do, you can make the federal funding contingent on full programs, but we can't force the states or whatever regulatory agency setting up the drug courts to offer this. They just can't get federal money if they don't offer it.
The committee is actually going to be talking at state level because, as a former state administrator, states do play a crucial role. There are many, many programs out there that actually don't receive federal funding or drug courts that don't receive federal funding. We hope that our policies and procedures are adopted by those non-federally funded programs. But states play a key role in licensing treatment programs.
Thank you.
And they, I think, can look at the opportunities of increasing or ensuring that state license of treatment programs also have the same kind of language.
Thank you. Speaking of states, go to the gentleman from West Virginia, Mr. McKinley, for 5 minutes.
Thank you very much, Mr. Chairman, and thank you again for these hearings that we've been having on this topic. As an engineer, I need to see things in perspective, so I've been following this over the last 4 years in Congress, and especially on this committee. Been trying to look at this issue, and I think at one of the last meetings we just had, I tried to put it in perspective by saying, from Botticelli, you said there were 44,000 overdose deaths. That I want people to understand that's more than died in Vietnam in combat. I don't know if the American public understands that. And every day on the news, NBC or whatever, they had body counts and they had that, and people were outraged over that. I'm not getting the sense of outrage over every year we lose as many people with drug overdose as we did in a 10-year war in Vietnam. We just seem. I'm concerned when I had affirmed that in West Virginia, 1 in 5 babies born in West Virginia, and I'm sure it may be 1 in 4 in other states or so, but 1 in 5 baby they've been affected with drugs. I keep things in perspective by saying, in Europe, the overdose rate is approximately 21 per million. In America, it's 7 to 10 times that amount. I get a little on the verge of outrage. I'm father of 4 and grandfather of 6. And I say, these are what we're giving our kids. This is what the future is. And I hear this testimony from this panel of 7 and the 7 before that and the 7 before that. And quite frankly, I get confused because I don't know what the priority is. From the business community and you all here in Washington, everyone loves to plan, but they don't carry out. Now, that may be insulting, and I don't mean it in an insulting fashion. But we still have 44,000 people will die between now and next year because we don't have a prior. I'd like to think that we could come up with one plan, one way, at least one, prioritize it. What's the one thing? And then let's put everything we have into it, that Manhattan-style project, go after that one solution and see if that doesn't start the ball rolling in the right way. And then we can do 2, 3, and 4 with it. But a focus. But I don't see a focus. I didn't see a focus from you. I heard 7, 8 different ways that we might be able to approach this problem because the plan, everyone loves the plan, but the implementation falls short. So since you're meeting on a regular basis, couldn't you come up with one idea to where we ought to begin? To where we can really, the metrics, the optics, everything, we can really dig into that, and then we can have plans B, C, and D, but let's achieve one instead of continuing to melt down as we do at this. I don't want to see another statistic of 44,000 more people die of overdose. So I hesitate to ask, can you come up with an idea today in the time frame? Is there just one idea that we should focus on? What's the best way? Is that in the drug use? Is that in real time on purchasing of prescription drugs? That it's a national database? Is that the number one thing we should do? I mean, my God, the federal government's just changed its sentencing guidelines for heroin, and they said if you're caught with 50 hits of heroin, you get probation. What are we doing? Are we fighting heroin or not? I'm really frustrated with this, so give me some more guidance on Plan 1.
I appreciate your attention to this, and myself and many of our colleagues have been doing this work for a long time, and I think are filled with a sense of tragedy in terms of where we are, and know that we can do better, and know that we can work with Congress. You asked for one. I think there are 3 areas, and some of these are articulated in the Secretary's plan that we've got to do. We've got to change prescribing patterns in this. We are prescribing way too much medication, and that's starting the trajectory. We need to increase our capacity to treat the disease so that people who go down that path have adequate access. And the third is that we really need to focus on reducing overdose deaths. Those are 3 areas that I think we can work with Congress on to really look at how do we increase our efforts.
Let me add on to that on behalf. It seems that people from West Virginia all sort of think alike that way, and our secretary, who is shares the same experience you do, is pushed us to focus and to take action in those 3 areas. And with it this year, we more than quadrupled our funding in those areas, and we're going to triple that again if our plans goes through. And these are in those 3 focused areas because that's where the evidence says we should be doubling down, and that's sort of what is guiding us.
Thank you. Is the Secretary asking for legislation on this then to facilitate the answer to that question?
There are some legislative proposals, and some of it is just increasing some of the use of our discretionary funds, and we got some additional appropriations this year, and then in the President's budget we have sort of some legislative proposals for.
Would you please let this committee know if there's enabling language we have, and that would help address Mr. McKinley's question. Yep. Thank you. Ms. Clark of New York, you're recognized for 5 minutes.
I thank you very much, Mr. Chairman and our ranking member, and thank you to all of our witnesses for giving the committee the benefit of your expertise and experience today. I'd like to focus my questions on the prevention side of the equation. How do we prevent opiate addiction in the first place? So, Dr. Volko, picking up actually on a point that Mr. Botticelli made just a moment ago about way too many prescriptions, this is to you. Why are so many prescriptions being written for opioids? Are physicians not getting the appropriate level of training and education in pain management, responsible opioid prescribing practices? What would you say?
They are both. Actually, what had happened is we have to recognize that there's another epidemic of chronic pain in our country, estimated 100 million people, according to the Institute of Medicine. As a result of the pressure of needing to address this problem, the joint accreditation required that hospitals and physicians in hospitals ask questions about pain and treat them. This was in 2000, and the problem was that was not associated with the education required in order to be able to properly screen pain, but also to manage it and use opioid medications adequately. So there was a big gap between the need to implement better treatment for pain, but the inadequate education of that system. So that is a major problem. I think that in terms of the prevention, we have to recognize 2 aspects on this epidemic that's different from the others. One of them, we do have individuals that start diverting and they get the medications because they want to get high. But then there's the other element that is as important of individuals that are properly prescribed the medication because they have pain. And in the past, it was believed that if you got an opioid and you had pain, you will never become addicted. Now the data shows us that that's not correct. We don't exactly know what percentage of individuals that will be treated for their pain will become addicted. The range goes enormously from none to something like 40, 60. So we have no real idea. So what we need, and that's why I highlighted the notion of we need to be very aggressive in the education of healthcare providers on the screening and management of pain, but also be very aggressive on the treatment, on the education of healthcare providers for the recognition of substance use disorders so that they can determine who's vulnerable and when a person that's properly being treated is transitioning and how to intervene.
Thank you very much. Director Botticelli, does ONDCP believe that the federal government should mandate continuing medical education on responsible opioid prescribing practices as a precondition of DEA registration to prescribe controlled substances? And can you elaborate on how that would work if that's the case?
Sure. We do support mandatory prescriber education. I think for all of the evidence that you've heard today, it's very clear that if we really want to prevent both prescription drug misuse and heroin use and overdoses, we need to stop prescribing these medications so liberally. There was a recent GAO report that showed that physicians get little to no pain prescribing, and actually veterinarians get more pain prescribing than physicians in the United States. So we don't think that it's overly burdensome to require physicians in this epidemic to have education. I think as you talked about it, we'd have to work with the legislature to look at changes to the Controlled Substances Act to ensure that a certified continuing medical education program would be linked to the DEA licensure or relicensure process, and that we would monitor both the oversee those courses that we believe have the core competencies that we think are important and monitor who takes those.
Very well. Thank you very much. Dr. Throckmorton, manufacturers of opioid pain relievers are currently required to offer free voluntary education to physicians or responsible opioid prescribing practices. However, as I understand it, physician participation rates for these voluntary educational courses are fairly low. Is that correct?
We do have those programs in place. They were put into place about 18 months ago, and so the initial year was spent putting into place a process to allow the education to be available, prescribers to make use of it. During that time, we saw about 20,000 prescribers that are using extended release long-acting opioids sign up for one course. That's true. 20,000 out of around 320,000 prescribers that prescribe these medicines is not a large fraction. It is progress. What we hope is in the second year, which will end in July of this year, we'll see a larger increase in terms of uptake and use of this education. We've been working with the continuing education community to make better use of it, make it more available. We're optimistic. We hope that we'll see more use. It's one of two pillars of education from our perspective, combined with the mandatory education that Mr. Botticelli just spoke about. We believe both of these things provide important opportunities to educate prescribers.
Very well. I yield back. Thank you very much for your
Thank you, Ms. Brooks of Indiana. 5 minutes.
Thank you, Mr. Chairman, for continuing the focus on this critical subject for our country. I want to start with you, Dr. Volko. We talked about how the opioid addiction facing the country is in large part due to chronic pain, and you mentioned 100 million people suffer from chronic pain. I've heard up to 1 in 3 Americans actually possibly suffer from chronic pain. And one of the goals of this hearing is to try to focus on evidence-based treatment and new treatments and try and find out what it is that is working. And obviously one treatment doesn't work for everyone, as we've heard. But I learned about in the course of examining this, that there are some technologies that are new, not completely new, but one being, I was told about, spinal cord stimulation, which targets nerves with electrical impulses rather than drugs, and that clinical studies have shown it to be safe. 4,000 patients have received the stimulator, and so it obviously is a device, a technology that can actually stop that stimulation and can help hopefully end that addiction. But yet NIH hasn't included that in its draft pain strategy. It didn't mention technologies like SCS. Can you talk at all about why it wouldn't be promoting this FDA-approved type of technology, and are there other technologies we ought to be talking about other than medication for chronic pain?
Thanks for the question. And indeed, this is an area that is rapidly evolving, and if it's not mentioned, it's because many of the findings are way too recent. And the one that you're commenting in terms of stimulation is one of the strategies that we're also promoting research. And the same strategy can be utilized to be able to actually inhibit the emotional centers of the brain that react to pain. So researchers are utilizing a wide variety of tools and technologies that have evolved as part of our initiative to understand the brain. That again highlights, but it brings up something that I think that that is facing us in this epidemic, the need that we have to develop better strategies for the management of chronic pain. Because the physicians are forced, patients in great suffering, they don't know what to do and they give an opioid, even though the evidence does not really show us that they are very effective for the management of chronic pain. But there are not many alternatives. So recognizing that this is an area where we require to invest resources for having alternatives for patients suffering from chronic pain is an extremely important part of the initiative of addressing.
How would you recommend that we increase then patient access and educate more physicians about this type of technology?
Well, this is a new technology. Some of them, actually, the evidence is just emerging. It will have to be submitted to the FDA for approval, and then physicians, as part of their training, should be exposed to them. And I would say, I'm just highlighting in the notion because Michael Botticelli very clearly delineated, I also think it's important that medical students, as part of their basic training, have an understanding of these technologies, because pain is part of every medical condition, almost of every medical condition.
Thank you very much. I'd like to ask you, Mr. Botticelli, my state of Indiana, recently passed a law allowing physicians to prescribe the naloxone to parents and to others and friends, giving them greater access to the reversal heroin drug. Would you speak as to what's known about the impact of the naloxone programs and whether you have concerns about whether the naloxone might encourage actually more risk-taking? Because I met with law enforcement who said they had given people naloxone, had saved their lives, and a couple weeks later saved their life again with naloxone. And so I am somewhat concerned, and I absolutely want to save lives, and we must, but yet, and we know there aren't enough treatment. This is obviously a huge problem. But might that encourage an addict if they knew their mom, dad, or friend had the save right there? Can you talk to us about these naloxone programs?
Sure. So to your first question, obviously naloxone distribution by as many people who have the potential to witness an overdose are particularly important, and law enforcement, particularly in rural counties, play a key role in that effort. I will tell you by way of when I was in Massachusetts, we significantly increased access to naloxone and actually did a peer-reviewed study that showed when you introduce naloxone into a community, overdose rates go down. And the more naloxone you introduce, the better the scale effect. One of the pieces that we are concerned about, but there is absolutely no evidence to show that naloxone distribution actually increases drug use. Some of the issues that you mentioned become critically important, that overdoses are often seen as a significant motivator for people to seek care. But having treatment on demand is a particular issue. Treatment on demand, particularly in some of our rural communities, is particularly an issue. Interventions at our emergency departments to get people into care become critically important. So while we know that some addiction is a chronic disease and some people do continue to use when you have these adverse events, but we also need to know we have to have a comprehensive response, not just saving someone's life.
Thank you. I completely agree, and I certainly hope the results in Indiana prove out to be the same as in your state, and I yield back. Thank you.
The lady yields back. Mr. Mullen of Oklahoma, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Before I get to some questions, I got a follow-up question for Ms. Hyde. The last time that you were in front of this committee, which I really appreciate you coming back, we had discussed your websites and if they were an effective use of taxpayer dollars. At that time, you stated that you all were in the process of evaluating that. Have you finished that process yet?
That process continues. Thank you for asking the follow-up question. The process continues I think the website that you indicated most concerns about was one of the websites that we were in the process of reviewing. It was originally developed based on data and knowledge from NIDA.
Right, and that was for the 3 to 6 year old for suicide prevention. Have you finished that one yet?
Yeah, building blocks, I think,
right.
is the one you were concerned about. We have worked with our colleagues at NIDA and determined that the website hadn't been updated in a while, so it needed to be updated. So we have taken it down and are in the process of updating it.
Could you give me some process reports on that, just so I can kind of know where you guys are at? We just want to make sure that taxpayer dollars are being used in an effective way.
Certainly.
To get to the questions, Dr. Throckmorton, just a simple yes or no. Does the FDA recommend that methadone be used as a first line of therapy for chronic pain?
Methadone is approved for use for pain, yes.
Is it, but specifically speaking to the first line, for a first line of defense, basically?
It's one of the medications that we've approved for pain. I will say, however, that if you look at methadone, if you look at the labeling that we have for methadone, it calls it out as far as a product that has particular characteristics that make it challenging to use for pain.
So that'd be a no for the first line. As a recommendation.
Our recommendation is prescribers think very carefully before using methadone. There are things that make it a challenging product to use. It is approved for use in that setting, but I hope doctors think very carefully before they do it.
Well, the FDA put out a warning about the drug safety and basically said that that insurers should not be referred as a preferred therapy unless special instructions and education was put onto it. So I would take that as that the FDA would, by this statement, that it'd be a no, that you wouldn't recommend it unless there's a lot of consideration taken.
Personally, what I just said is where I would be. Okay. I'd need to look at the statement and get back with you about the specifics of it. But okay. it is a drug that has a very long half-life that's variable patient to patient. It has unique cardiac toxicities. There are other drugs that are useful for pain that don't have those characteristics, sure. And
all I'm really looking for is a yes or no, because we're really trying to get to farther on down the lines of questions. But I do appreciate you being here, and I like the last name. That's my sister's last name, and I got
a very good last name.
I know I got 3 beautiful nieces, but the spelling usually gets messed up. Dr. Howery, what about the CDC? Do you guys consider this methadone as being a first line of defense for pain?
At CDC, we've just focused really on the primary prevention and not as much of the care, so I would defer to the sister agencies on that.
Which would be?
The panelists here, FDA.
well, Dr. Throckmorton kind of gave his personal opinion, but the statement of FDA you heard about. So would you follow the statement, I'm assuming?
I would follow his statement. I don't have a personal opinion on methadone for pain. It's not something I did in my prior practice.
Okay. Dr. Conway, by the way, I'm always jealous when people have their family with them. I got 5 wonderful kids, and if you ever want me to see me cry, that's about the only thing that'll make me cry. I miss them.
How are your kids doing?
Thanks. I appreciate that. I'll take a deep breath and wipe the tear away. Are you aware that methadone accounts for 30% of overdose deaths, while only accounting for about 2% of the prescriptions that are prescribed for chronic pain?
I am aware that it's a higher percentage of deaths compared to prescriptions because of the long half-life and risks described.
Would you personally recommend it as a first line of defense for pain?
So I'm a practicing physician. I do not, as a practicing physician, typically use methadone as a first defense. However, I think it depends on the individual patient characteristics and would defer to the physician's judgment with that individual patient.
Well, according to the Pew Research, they put out a deal that said methadone is available in low-cost generic form and is considered a preferred drug in many states by their Medicaid programs, despite FDA warnings about the drug safety and the statements by the American Academy of Pain Medicine that insurers should not be preferred this therapy unless it's specially educated and provided to the individual. I just kind of wonder if overall I would think we're considering it not being there. Why is this still listed as a first line with Medicaid. I mean, when we're seeing so many deaths, it almost makes you think, is the cost of a life not more valuable than the cost of a low drug?
So I'd make a few points. Statutorily, the Medicaid programs have the ability to set their preferred drug list. However, we've taken a couple of actions that I think to try to address this issue. One, working with SAMHSA and NIH and others on this panel, we put an informational bulletin to the Medicaid programs talking about this issue and a complete array of pain, both on the medication side, the risks of methadone, and the other options, and also importantly, as others have said, the importance of both behavioral treatment and medication treatment. I'd also call out in our Medicaid Innovation Accelerator program, the first area we're working on is substance abuse disorders. We've had over 30 states involved, and they're taking a comprehensive approach in the Medicaid program to appropriate substance abuse treatment, including appropriate use of medications and also other therapies.
Dr. Conway, appreciate it. Mr. Chairman, I yield back.
Mr. McKinley has a follow-up question, then I have a follow-up question too. So, do you have
thank you for the opportunity to just follow up, because one of the questions or statistics I was giving you in talking about perspective is the model or the situation that they're facing in Europe. When we have there in Europe, the average is 21 per million, and I was just looking at that's the average. Italy is below that. Latvia, Netherlands, Belgium, Greece, France, Poland, Portugal, Bulgaria, the Czech Republic, Slovakia, Hungary, Turkey, Romania, all have less than that, significantly less. What are they doing right? What are they doing differently in Europe than we are in America? Are we learning anything from them?
There is something that we're doing very differently, and you pick up exactly on the point. If you look at the United States, for some of the medications, we may be consuming 95% of the total production in the world. So the question is, are we a nation that is so much in pain that we require this massive amount of opioid medications, or is there something that we are doing in terms of their access to them that it's inadequate? And I want again to reiterate the notion that yes, we are over-prescribing opioid medications on the one hand, but at the same time, which is not exclusionary, sometimes we are under-treating patients with pain. So we are in a situation that we have it bad in both ways. We over-prescribing, making these drugs available, which then can be easily diverted, and prescribing them to those that don't need them can also result in adverse consequences. You don't see that level of prescriptions in none of the European countries.
So why not? What are they doing? Are their doctors more sensitive to this issue than our doctors in America? Are they concerned about the trial lawyers? What's the difference between it? If there are 10 to 15 times more people dying in America than there are in Europe, something's wrong. They're doing something differently, and I'd like to know what it is.
And that's one exactly the way that I say we have to aggressively institute the education of the healthcare providers on the proper screening and management of pain. That's a crucial component, while also educating them about the adverse effects as it relates to substance use disorders. And we need to face the fact that we need to also provide with alternative treatments for the management of chronic pain that are effective.
You're back. Thank you very much for that.
Ms. Collins, you have a quick question? Ms. Brooks, I'm sorry. Look at Collins' name behind you. Where am I going?
That's quite
Where am I going?
Thank you. This is actually, I realized Mr. Botticelli mentioned it in his opening, and I wanted to have an unrelated follow-up, if I might, Mr. Chairman.
Yes, you may.
You mentioned, and we are having a crisis in Indiana with respect in Scott County, a community of 4,300 people, an outbreak of HIV due to needle exchange. And I would simply like, and I hope that many of you have been following what has been happening and the number of citizens in Indiana who now have contracted HIV because of their, in all likelihood, heroin addiction, right? Or prescription drug addiction. and possibly heroin addiction as well. I'm very curious, since I have this incredible panel of experts here, what you might say to our state and to the health professionals who are public health professionals who are dealing with this crisis, to our state and local government officials. What advice and thoughts do you have for our state? And I truly, if we could, this is a crisis in our state that I think could be in any state in the country. Mr. Botticelli, and then anyone else who might comment, please.
So first of all, just about staff from all of the agencies on this table coordinate on a daily basis in tight coordination with the Indiana Health Department to make sure that we're giving Scott County the resources they need to do that.
Thank you, and I'm sure Dr. Adams appreciates that.
You're absolutely right that while we've seen huge, I think we're over 145 cases of HIV now, one of the consequences we've seen nationally is increases in viral hepatitis as it relates to sharing needles. And I think it also points to some issues that we need to include about access to treatment services. So I think what's happening in Indiana and Scott County is emblematic of the potential that we could see in other parts of the country, but point to some of the issues that we've been talking about today in terms of making sure that people have access to good care, both infectious disease care and substance use care. They have adequate access to clean syringes so that they are not increasing infection in this most poignant case of what we need, and that they're having timely access to treatment services, I think, are all areas to do that. We'll continue to engage with folks in Scott County to make sure that whatever we can do on the federal side can help alleviate the situation.
And I'd just like to add to that, I'm really proud of all the efforts CDC is doing on the ground in Indiana and in conjunction with the agencies here. I agree completely with Director Botticelli about the access to medication-assisted treatment as well as the HIV therapy. The other thing I would add is Indiana is number 9 in the nation for prescribing. And so there's a lot that can be done when you're looking at, again, trying to stop the epidemic before it even happens. So looking at, again, using the prescription drug monitoring programs, having better prescribing guidelines so that people don't get addicted to opioids to then inject them. So that's the third component I think we really need to add.
Dr. Volko? Or I'm sorry, and Administrator Hyde. Maybe Dr. Volko and Administrator Hyde.
Yeah. There's another, I mean, we got caught by surprise with the Indiana epidemic of HIV, and I heard Tom Frieden said this is the fastest growing incidence of HIV cases that we've had since the HIV entered the United States. But there's been an extraordinary advance on HIV that has emerged really over the past 2 years, past 2-3 years, which is that if you initiate someone on antiretroviral therapy, not only are you going to be improving their outcomes, but you are actually going to dramatically decrease their infectivity. So in looking towards it, one of the things that I would have suggested to do is once you start to see a case, you immediately treat them with antiretroviral therapy. They'll do better, and their infectivity will dramatically decrease. So this is another aspect which actually relates to the issue giving a care to good infectious disease care to these individuals jointly with interventions for substance abuse treatment.
Thank you. And
so I just wanted to add that we are working collectively on this issue and that we understand there may be some legal barriers that we've been talking to Indiana about in terms of developing opioid treatment programs, and there's not a lot of waivered physicians able to provide buprenorphine. I think the closest opioid treatment program is about 40 miles away. There may be some transportation barriers and cost barriers and other things. So we're collectively working with the state to try to help develop alternatives.
Thank you, Mr. Chairman, for allowing me to
Thank you. I have
voice.
2 quick follow-up questions. First, Ms. Hyde, last week the subcommittee heard testimony from Dr. Anna Lemke, the program director of the Stanford University Addiction Medicine Program, that the 42 CFR Part 2 is an artifact of the past. She told us the law's consent requirements are so stringent that 2 doctors seeking to treat the same patient for opioid addiction can't communicate with each other about the patient's medical condition. In fact, she cited that the subcommittee, and we received subcommittee reports, the rule is based upon a 1972 law, and it's causing havoc in the age of electronic records. I guess sometimes when police would actually raid a methadone clinic and arrest people there. Now, so she had strongly recommended we change that so we are not overprescribing people and we know a physician can know who's in treatment. Now, my understanding is that SAMHSA is contemplating new 42 CFR Part 2 rules. I just want to know if you're committed that these rules will reflect the concerns that have been repeatedly voiced by so many in the medical community who treat patients with substance abuse, who want nothing more to make sure patients aren't given double doses they can really communicate. Is that what SAMHSA is going to be working on?
Really appreciate that question because it is a complex issue, and you're right. These laws and regs are decades old. Before we had electronic health records, before we had collaborative care models and other things that we are now considering part of practice. We, a couple of years ago, put together some sub-regulatory guidance to try to help this issue, but that wasn't sufficient. So last year we held a listening session for stakeholders and have taken those pieces of input and are trying to balance the privacy concerns with the need for access to data. We hope that we will have something available for public input yet this year to try to address some of these issues.
And please let the committee know. Thank you. And Mr. Bonicelli, I want to follow up on this Kentucky drug court issue. Could the drug court's decisions relate to the issue of diversion? I mean, at a previous hearing, we heard testimony from witnesses that Suboxone mills are popping up in Kentucky and West Virginia, and these are high problematic states. And when entering the drug court system, it's nearly impossible to determine if the Suboxone is from an illicit source or prescribed by a doctor. Could this be part of the issue, and the drug courts could make the drug courts could really work and perhaps have some flexibility to deal with this on a case-by-case basis?
So I think there are a number of issues. The National Association of Drug Court Professionals actually did a survey of drug courts in the United States, and for those drug courts that were not referring, it was actually more about judicial bias than it was about fear of diversion that kept people from doing that. I think the second piece, that any treatment, whether it's medication-assisted treatment or residential treatment, requires a level of collaboration and relationship between the court and the provider to ensure that courts who are referring to treatment are referring to high-quality treatment. You know, we do need to pay attention to diversion, and drug courts, I think, in combination with treatment programs, can ensure that these are appropriately prescribed and appropriately monitored medications. And they need to make sure that they're partnering with physicians who are implementing and dispensing medications in a high-quality way.
Now, part of this, I just got an article that was, I'm not sure what newspaper this is, but it was talking about in some of these courts, they're using Vivitrol. And for people in and out of incarceration, trying to keep them off by maintaining Vivitrol. So I just want to make sure I understand. They want to keep these people after they're released from prison drug-free. And so could you please clarify? Are you saying that unless they have some synthetic opioids, they're going to have federal funding cut, or they can still maintain federal funding, and that Vivitrol would be acceptable as another part of the program?
So we don't dictate to drug courts what medications. That actually should be a decision between the treatment provider and the patient. I think our work here was just to make sure that there weren't categorical prohibitions for drug courts either to not offer medication-assisted therapies, and if someone was on a recommended course of treatment, that they not have to get off the medications to do that. We actually don't dictate what medications courts use to be able to do that. I think like any treatment, you want to have an arsenal of medications.
Dr. Frank, could you also respond to the Vivitrol question too? Did you hear that, or is that? I'm just wondering about that as an option for states as a diversion to be using Vivitrol, that could be part of what we could be. Microphone, please.
I think that we are trying to have the full armamentarium available to the treating providers. We're trying not to get between the provider and the patient, as long as there's the opportunities to offer the the richest menu of evidence-based treatments that are available.
Mr. Gate, you have a follow-up?
Mr. Chairman, Mr. McKinley asked the witnesses, what one thing would you recommend that we could do to try to start reversing this epidemic and this problem? He got as far as Dr. Frank when he ran out of time. So I just ask unanimous consent if we can ask each one of the other witnesses to supplement their testimony. They don't have to say it right now.
Get back to us.
But if you can get back to us with that recommendation, we recognize there's a problem, and we are really struggling with the issue of what we do as a Congress to remedy it. Thank you.
Thank you. And I think what you're also talking about, a partnership with the states, says we should be looking at Kentucky and some others, Indiana and others, Colorado, of course, and see what else is going on. I want to thank this panel. We will follow up with other questions because we heard a number of recommendations from you, so we will ask for more clarifications of this. Look, I want to thank you. As I said last time, too, you know, if this was about a single airplane crash, the room would be filled with media. But we have had more people die in the last year from drug overdose deaths than the combination of every airplane crash in North America from 1975 to the present. And we have to make sure we keep this on the front page. This is a serious crisis, and one, whether it's education of physicians, mandatory education, whether it's options out there, we want to make sure that evidence-based care and that federal funding is going the right direction. So I'd like to thank all the witnesses and members that participated in today's hearing. I remind members they have 10 business days to submit questions to the record, and I ask that all the witnesses agree to respond promptly to the questions. And with that, this committee is adjourned. Thank you.
You too. Glad you had your kids here.